A warm welcome back, everyone. I hope that you managed to grab a drink, a cuppa, a water, or maybe even following Jane, you grabbed a cider. The wonderful thing about having a virtual content conference is that you can enjoy the content as you would like in the sunshine or in the comfort of your own home. And if you're listening to this again, welcome. Uh, and I also want to welcome any colleagues that are joining us for the first time across the Americas. Some house business of house order. You will see the Q&A to the right. Do please put in your questions at any point in time, and also feel free to engage in the discussion during the session as well as afterwards and during the conference. I have the honor of introducing Professor Mary Dixon-Woods, who will present on what kinds of evidence are needed to improve healthcare systems. I think this presentation will resonate with colleagues both inside and outside of healthcare systems. A little bit of background on Mary. You could talk for ages about all of her accomplishments and qualifications, but she's the director of the This Institute and is the Health Foundation Professor of Healthcare Improvement Studies in the Department of Public Health and Primary Care at the University of Cambridge. This institute is about creating an evidence base that supports replicable and scalable improvements and creating a world-leading scientific asset for the NHS about how to improve quality and safety in healthcare. She's a fellow of the Academy of Social Sciences and the Academy of Medical Sciences, an honorary fellow of the Royal College of Physicians and the Royal College of General Practitioners, a professional fellow at Homerton College, Cambridge, and a National Institutes for Health Research, NIHR, senior investigator. Mary leads an ambitious program of research focused on healthcare improvement, healthcare ethics, and methodological innovation in studying healthcare. She has a really, really fabulous set of slides that I hope you all enjoy. She'll talk for maybe about 35 minutes, and then we'll get to kind of the question answer. So do pop in those questions during her presentation. Thank you. I'll hand it over to Mary now.
Thank you very much, Ellie, for that lovely introduction, and to you all for joining me this afternoon. I'm going to talk about the different kinds of evidence we need to improve healthcare systems, and I'm going to organise my thoughts under a relatively simple or deceptively simple cyclical model. And I'm going to talk through some of the forms of evidence we need to inform each of these elements. Those kinds of evidence, the kinds of evidence we need at every stage is likely to be quite diverse. And some of what I'd like us to talk about this afternoon are the kinds of evidence we would need to secure improvement as we seek an evidence base for healthcare. So I guess the first point is that measurement is fundamental to improving quality and safety of care. And this is consistent with the first element of our model. I'm sorry, I'm having a little bit of difficulty with moving the slides. This is consistent with the first element of our model, which suggests that your first job is to improve it, to monitor it and explain it. And this starts with having data available on variations. And this is something we've known going back to 2000 years, really. If we look at the example of tonsillectomy, and this was a surgical procedure that until relatively recently was very frequently performed, actually particularly in children. And it wasn't until the work of James Allison Glover in the early part of the 20th century that there was an attempt to systematically examine what exactly was going on with tonsillectomy. And his achievement was to identify that there was widespread variation in the frequency with which this operation was being performed in the UK. So striking contrasts in areas apparently similarly circumstanced. The operation rate in 1931 in Margate was 8 times that of Ramsgate, for example. What was also clear was that this was not an entirely benign intervention. There was an 8-fold variation in risk of death after the operation, and in a 4-year period, over 500 deaths following tonsillectomy. So this was not a trivial discovery. This was identification of a variation that really was highly consequential. A very important conclusion of Glover was that the variations he had identified defined any explanation save that of medical opinion on the indications for the operation. We'll return to this theme of what explains what you see when you seek to examine variation. Now, Glover's work kind of got neglected for a while and then really got rediscovered in the 1970s with the work of Jack Wenberg in Vermont. And this paper really was quite crucial. It described what he calls small area variations in healthcare delivery. And in this study of variation in interventions in New England, he discovered again what Glover had found in England 40 years earlier, which was a 17-fold variation in the rates at which tonsillectomy was performed, which again couldn't be explained on the basis of underlying population characteristics or underlying need, and a 6-fold variation in hysterectomy, to the extent that there was one city in northern New England where virtually no woman had her womb after the age of 50. And Wenberg again concluded that what he was seeing was unwarranted variation that could not be explained on the basis of illness, medical evidence, or patient preference. And that work continues to inspire the study of variation that we see today. The Dartmouth Atlas of Healthcare continues to map variation, currently, in fact, mapping variation in COVID, and has inspired other atlases of variation around the world, including Australia and New Zealand. The concept of variation remains extremely important in all kinds of studies and all kinds of attempts to monitor quality and safety of care. A very popular technique, for example, continues to be audit of practice against established standard. And there we see, for example, that typically you find that there is variation from the standard, and that some units are capable of, for example, delivering evidence-based practices to improve survival of preterm infants much more than others appear to deliver the same standards of care. So that effort to monitor and assess variation is really, really critical to any attempt to study variation and to do something about quality and safety in care. But what I'm also going to propose is that explaining the variation is just as important. One of the first things that anyone who studies this area will want to look at is what explains the data in terms of the data itself. So the challenge of understanding the underlying issues in collecting and interpreting the data will often be a key task for researchers. And what we have identified when we have attempted to study this, what happens when people try to collect data on quality of care, is that we repeatedly identify just how challenging it is. All kinds of problems attend the selection of measures, the collection of data, and its interpretation. So it's really a very challenging task to collect data on quality of care, and therefore we should expose the data themselves to scrutiny. We also know that there is a lot of challenge in actioning the data that's produced through efforts to monitor quality and safety in healthcare, and that's an area that needs increasing attention as efforts are made to try to improve quality and safety. Explaining the variation once you've got past the problem of explaining what might be the issue with the data may require many different forms of investigation and evidence. And if we return to the tonsillectomy example again, the fantastic work of sociologists like Mick Bloor not only helped to identify and characterize geographical variation in operations on tonsils, but also through this wonderful qualitative work, ethnographic work collected in ENT clinics, was also able to explain why it was that this variation was occurring. Now, in the case of tonsillectomy, he came to a very similar conclusion to Glover himself, which was that it was the decision rules being used by surgeons that explained the variation. So this was extremely important because essentially what it was showing was that you need different ways of explaining what you're seeing in the quantitative data that cannot be found necessarily in the quantitative data itself. We were able to use this work to help inform the model we developed of how you explain different forms of help seeking, access to healthcare. So that the conceptual model we developed there was based on synthesizing a very large literature, both quantitative and qualitative, to come up with a model of access to care. And this literature helps to explain why it is that these variations, particularly in the rate at which interventions are offered and performed, occur. What's also important is that measuring the variation by itself doesn't give you the whole story. And really important is that you may need other forms of diagnostics to understand what the challenges are that affect quality and safety in healthcare systems. And I think to some extent we've kind of remained within the grip of an epidemiological model, which is extremely valuable, but doesn't give us everything we need to know about quality and safety. So one of the very promising developments of recent years has been the evolution of methods based on human factors principles and engineering that describe systems of care. Some of this work has been led by Pascal Carrion, for example, the SEEPS model. And I think this has much more potential than has currently been realized to help in characterizing and diagnosing where the challenges might lie in healthcare systems that then need to be addressed. We're also, particularly in the last 10 years, beginning to see the development of really exciting models that use simulation techniques to study how to improve quality and safety in healthcare. And this is something I'd really like to see more of. One of your colleagues in Australia, Victoria Brazel, has been a world leader in this area. And some of her work is absolutely inspiring, using simulation to diagnose challenges in healthcare systems and to develop and test interventions that can help in improvement. So really exciting work beginning to appear that offers highly systematic ways of diagnosing what's going on in healthcare systems and giving us new forms of knowledge. This is really important because some of the most important forms of knowledge about what's going on in terms of quality and safety challenges may have this highly fugitive character, such that what's concealed or left unmeasured may matter at least as much as what's revealed through quantitative measures. And this was something we discovered very vividly, really, through a very large study we did of culture and behaviour in the English National Health Service. This is a large multi-method study, but essentially what we found was that the quality of the data, the quality of the information, the quality of the organizational intelligence available to hospital boards was highly variable and needed to be rounded out through really deep understanding of soft intelligence. And that may not be very easily come by. Soft intelligence will be the kind of intelligence that by its nature evades measurement and is most easily gained through really deep listening to staff and patients. And when we've seen this work, it works really, really well. There was a really interesting example actually on Twitter over the weekend of a senior nurse who'd spent the day with an environmental hygienist and was blown away by the skilled nature of the work that was being done and the kinds of challenges that are encountered in doing that kind of work. So listening to different voices, listening to staff, listening to patients is really important. Another very interesting and very powerful example from Twitter, discussing a patient's experiences of having delirium. So this is a condition that affects 20 to 30% of patients admitted to hospital and is extremely distressing with often long-lasting effects. And she described how frightening the nights were. She showed this picture of what the view looked like from her hospital window, which looked entirely benign by day, but by night it looked very, very different. And she asks us to think about what you would see looking in a confused state at what you're seeing through the window. And it is, you're terrified just looking at it, even though you know what it is. So that's the kind of intelligence you might never get through measuring variation, but that you can get through listening to staff and patients. So I'm very interested in what we do to systematize soft intelligence without losing some of its vital qualities. And that to me is just as important to that kind of effort to monitor and explain, valuing different forms of evidence will be very important. A next challenge in, sorry, I am having trouble with my slide deck. Let me just return. A next feature of improving quality and safety in health systems is the use of methods to identify what good looks like. And that is often going to mean understanding what good looks like from multiple perspectives, including patients. This study that we completed, my colleagues completed over the summer, looked at care provided during COVID for quite vulnerable patient population with COPD. And one of the things we discovered through really listening to patients and staff and gathering their perspectives is that what patients think can be delivered remotely and what clinicians think can be remotely is not always the same. So you don't know what good looks like unless you make that kind of assessment. I'm just going to see if a slightly alternative way of moving my slides on may help. In terms of achieving what good looks like, it's clear we're going to need a much better focus on the right kinds of research approaches to support making the right way the easy way. And I sometimes think there isn't enough attention on what it's like to try to deliver care at the very sharp end. So there's an awful lot of research on incentives, penalties, all kinds of ways of seeking to improve care, but what it's actually like to look after patients isn't as well studied as it might be. And it really would benefit from more investigation. So there's a classic series of studies from Anita Tucker and colleagues in the US. And this was a revelation in terms of demonstrating the challenges of operational failures and interruptions in hospital nursing. And by very close observation of what nurses are doing, she was able to discover that nurses are interrupted every 6 minutes, and that they spend 10 to 12% of their time working around what she calls operational failures, things going wrong in everyday care. We're repeating that same study in primary care in the UK, and we're finding very similar kinds of challenges. So the problem that people are having to cope with operational defects in what they're doing is extremely frustrating and really gets in the way of quality of care. So very often staff spend a huge amount of time looking for things, sometimes fruitlessly, trying to assemble information that may be in many different places and isn't available in the form that they need it, and not having test results and x-rays available at the time that they're required, going to get equipment only to find that the equipment is unavailable or is broken or hasn't been cleaned. When we do observations in healthcare settings, people seem to spend an inordinate amount of time looking for keys. And this is often the mode in which they approach computers. So very frustrating work systems that people are asked to cope with. And that is where we could, using different forms of evidence, time and motion studies, close-up observations, we can really get to identify what it is that gets in the way of quality of care. In terms of doing that, it's clear we need to make more use of relevant disciplines that still have not got the same look in as the more epidemiological methods. And that means using things like human factors and ergonomics. As I mentioned earlier, the SEEPS model is extremely useful in helping to diagnose these kinds of challenges. Also, what's important, and I see this all the time with quality improvement activities, is a failure to recognize, I'm very, very sorry. I'm just having trouble with the slides are moving on of their own accord. going to let me go back for reasons best known to itself. What I see sometimes in quality improvement is failure to recognize the structural requirements that need to be in place in order to deliver quality of care. So basics like equipment, staffing, these are things that are absolutely crucial. And we know this going back to the work of Donna Bedian. In terms of what needs to happen then to make change, one of the key things is figuring out the right balance between norming, rewarding, and requiring. When we've looked at what that means, very often what you need to do is to have a really clear sense of what norming means. So how the norms in the situation operate, what good looks like, and how best you can make sure that the way people are behaving encourages improvement. But that has to be combined with organizational commitment and systems improvement. And when we have looked at, so for example, challenges like encouraging voice in organizations, it's clear that when norms are not sufficient for people to feel they can step up and give voice to their concerns, you have to have really good systems that sit behind them. You have to have ways of taking over, intervening and supporting people in giving voice to concerns. Harder tactics do have a role, but they have to be handled with caution. And too often we see a kind of rush to using really hard tactics like penalties, incentives and so on, when actually you would be better intervening in the systems and in the cultural norms of situations. And one of the reasons I think I would be very cautious about this is that incentives clearly do matter, but if they're not designed really, really well, the danger is that you get unintended consequences. And there are lots of examples, but this is a particularly important one. So this was the introduction of penalties following in the US to encourage hospitals to reduce hospital-acquired conditions. And this showed that introducing the penalties didn't reduce hospital-acquired conditions, didn't affect clinical outcomes, but it did punish hospitals caring for a higher proportion of disadvantaged patients. So here was a program that basically didn't achieve its goals, but did end up causing unintended consequences. Again, when we've studied this kind of thing qualitatively, we've found the same kinds of challenges, people reporting that penalties and other incentives for reducing infection, for example, can be extremely corrosive in terms of their impact on staff. And this study we did looking at a patient safety improvement program that wasn't even using penalties, but staff perceived that they were, showed that although its intention was to enable staff to take the temperature, so to assess what was going on in terms of patient safety, instead it was perceived as putting them in hot water, that it wasn't in their interest or the interests of patients. It was more of an organizationally driven, institutionally driven program. The next challenge in terms of how we do improvement is making sure that improvement can actually occur, that there are high quality interventions in place. And to me, it's a disappointment that we still don't have the evidence base to answer the question, does quality improvement improve quality? And this is because we haven't really built up the quality of evidence that can help address this question satisfactorily. I've outlined some of the reasons for this in an essay that was published in the BMJ, free to download for anyone who wants to look. But some of the, just to share with you some of the challenges that we discuss in that essay. One of them is that we have not really always evaluated quality improvement interventions in a way that yields the kind of high quality evidence that is needed. So in contrast with drugs, we have not really created the infrastructure for evaluating these kinds of interventions. That's not to say that there aren't methods available, but for various reasons, improvement interventions do not get the same attention, they don't get the same funding, there tends not to be the same attention to rigor. And part of that arises because improvement is seen as a local activity. There are now an emerging set of methods that we can use, as well as very well-established methods. And when they are applied, some of the results we find of efforts to improve healthcare systems are really quite sobering. So this is a very nice study of something that looks entirely plausible and like a really good idea for an improvement intervention, something people talk about in healthcare systems all the time, which is improving introducing an integrated care pathway. And this uses a really quite nice study, matched control cohort study. And the disappointing thing was that the integrated care pathway did not result in a reduction in healthcare utilization, and in fact instead appeared to have increased in elective inpatient admissions and general practitioner workload. So the integrated care pathway did exactly the opposite in terms of what was intended, in terms of reducing use of service. It may have produced other benefits. Patients may have got, there may have been unmet need that was picked up through this, but it very powerfully argues for why we need to do evaluation. And the reason for that really lies in a kind of very long established problem in evaluation, which is what I like to call the lovely baby problem, but was described very beautifully by Donald Campbell in terms of a kind of conspiracy of enthusiasm, that there's a tendency to argue that things are going to be successful, or they're certain to be successful, and we have to be able to advocate without the excess of commitment that binds us to reality testing. And one of the things we see quite a lot with improvement interventions is that they're often the brainchild of a particular group or particular individual, sometimes a particular hospital, and they acquire the status of being that group's baby. And as we all know, everybody thinks their own baby is particularly lovely. But again, once you start to expose some of these ideas to more rigorous evaluation, they don't always turn out to be quite as good as you would hope. So this is an interesting example. I mentioned earlier that nurses are interrupted all the time. And one solution that's been widely proposed to address this has been asking them to wear tabards, which signal that this is a do not disturb situation. Actually, an idea that dates back a very long way to the medieval period, in fact. But it wasn't evaluated until relatively recently, and a very nice Australian study, cluster randomized feasibility study, discovered that not only does the intervention not reduce interruptions overall, it has a small effect on drug-related interruptions only. It's basically not worth the candle, but it's also not popular with a lot of nurses or staff. So the conclusion, I think, is that not all of our babies are lovely, and we have to be rigorous about the design and evaluation of improvement interventions. Part of the commitment there has got to be to generating theory and accumulating knowledge as we do these evaluations and do studies. And this is really, really key. And I think, again, has been repeatedly demonstrated. There's this very nice study of the effects and costs of implementing predictive risk stratification in primary care. Again, it looks like a jolly good idea, which is that you stratify patients and then you can kind of customize the care that you're going to offer them. Again, unfortunately, this randomized stepped wedge trial found that, in fact, the intervention increased hospital admissions and also increased use of other NHS services. And the authors made, I think, a very important conclusion, which is that such interventions need explicit models of how they will work and with whom, and rigorous evaluation of their clinical and cost effectiveness before implementation. And that's something I just wholeheartedly agree with. And we've been arguing for some time that we have to have a really strongly theoretically guided approach to theory and to the use of theory in improvement. So this paper, we identified just why it is that that theory has a very, very practical role in improving quality and safety of care. And we wrote this paper really to address the challenge that very often theory is seen as something abstract and of very limited relevance to the people on the ground. But let me just explain how we have used this in my own home to try and improve our quality of life. And one of the things that affects my husband's quality of life is the problem that the squirrels are extremely fond of the nuts that we put in our bird feeder. He's extremely interested in developing an effective intervention to tackle this problem. When my daughter was quite small and had just started school, she was very impressed with rules and regulations, and she had also just learned to read. And she proposed an intervention that would comprise a sign that would say, no squirrels, birds only. So we turned this into an examination of the role of theory. And we were able to identify that the advantages of her proposal were that there was a very clear goal. We also had the resource available and it was affordable. But then we examined the assumptions underlying the intervention. One was that squirrels could read, and the second was that if they could, they would comply with the directions. And after some discussion, we came to the conclusion that neither of those assumptions could really be justified. So we then turned to an alternative possibility, this time proposed by my husband. And his proposal was that we used a bottle that would be deployed as a kind of baffle on the pole. So again, we subjected this to the same examination. Again, we've got a nice clear goal. We felt we could mobilize the resource that was going to be needed. And we looked at the two assumptions. The first was that the squirrel would encounter the physical barriers it climbed up the pole, and the second was that the squirrel would be prevented from progressing further. And both of those seemed to be quite reasonable assumptions. So we proceeded. My husband then made the error of boasting about the apparent effectiveness of this intervention to our neighbour, who published an article in the local newspaper commenting on this. And we then continued, consistent with good monitoring practice, to examine the situation further. And I'm sorry to say that we concluded after an experimental period that in fact the baffle, the plastic bottle, was not consistently effective in deterring the squirrel. So we were forced to update our theory. And our updated theory said that physical deterrents do have a role in stopping squirrels, but eventually the squirrel is going to find their way around it. And the big learning here is that you're in a lifelong battle of will and wits. So that kind of theory accumulation is really very important to improvement interventions. And if we don't get this, then it is very important. It is very, very difficult to replicate and scale what appear to be successful interventions, or we end up doing things that basically we know already don't work. This is a quite famous study now, about 14, 15 years old, that showed that you could reduce catheter-related bloodstream infections in the intensive care unit. They didn't do a qualitative study at the time, but we were able to develop a theory of what it was that had enabled this program to be so successful. We did that by essentially recovering documents and doing interviews with the people who've been involved in the program. And what we showed was that there were 6 things essentially that helped to explain why the Michigan program had been successful. They included peer pressure, creating a network community, reframing the problem as a social problem with a solution, having lots of interventions that functioned in different ways, not just one, using the data essentially as a form of encouragement. We use the term discipline in a sociological sense here, and using hard edges very skillfully. An attempt was made to reproduce the Michigan program in England. The program was called Matching Michigan. And the disappointing feature of this program was that it appeared superficially to be the same as the Michigan program. It had the same organization, the same interventions, and so on. But it didn't demonstrate the same impact in that the improvement that was occurring in England had already been occurring before the programme was introduced. So the programme did not appear to produce any improvement over and above what would have happened anyway. Qualitatively, we were able to explain what had happened here because we were doing both ethnographic and interviews as the programme went on. And essentially what we were able to show through this work was that the challenge here was one of fidelity. So essentially the programme failed to reproduce the mechanisms that we're seeing. I don't know if I'm still live, Ellie.
Mary, I think you're still live, but we've lost your slides there. It was amazing though, you were talking about reproducing and then you got reproduced in smaller and smaller boxes.
I don't quite, I don't know quite what happened there because I didn't touch the screen sharing, but I'll try again. I'm sorry, there seems to be some technical lag with my slides showing up. So I just, but anyway, I was actually on my third last slide, and what I was going to say is that the major problem with reproducing the programme in England was a lack of fidelity. Let me just see if we can get back there again. Yeah, can you see it now? Okay.
I cannot. We might just want to finish your presentation without the slides.
Yeah, I'll give it one more go and then we'll give up. Okay, I think we'll give up. I was on my second last slide anyway. So my major conclusion essentially is that if we're going to make improvements in healthcare, we need multiple forms of evidence. We need to value different methods, different approaches, different voices and perspectives, and we need to focus on diagnosing and explaining as well as describing. Sorry about the technical problems.
No worries, Mary. Thank you very much. It was definitely a tour de force and lovely slides. Sorry that we can't see the last few of them. We've had lots of questions coming in, so maybe I will hold out on some of my own, but I just wanted to right now think of some of the things that I know will stick with me from this presentation, one of which is the thought of that lovely baby and lovely baby problem, and that really key phrase, the squirrel story, and then our constant lifelong battle of will and wits, and our lifelong thought of how to improve the evidence, improving the theories, improving our mechanisms for change. And then that story of the nurses too, and how they get interrupted every 6 minutes, and the ways for change, and how we can often think historically and learn from the past as well as the present. So really quite a tour de force, aligns with some of the main themes that I've heard coming out from other presentations, thinking about variation, thinking about different forms of knowledge, and how to incorporate all of those. So to go to some of our questions, I'll go on here that links to one of the things that will stick out with me. So it's from Mary in Singapore, thinking, how do we get better at spotting our own ugly babies?
That is a great question, and I'm very keen that we build better infrastructures for doing collaborative development of interventions, and that we optimize these collaboratively. I think too much improvement work is essentially too local, and obviously it has to be local in the end, but I think we come up with solutions locally, get very invested in them and then don't evaluate them. I think that there's an awful lot to be gained by creating essentially large-scale collaborative infrastructures and by much better rigorous evaluation of the interventions.
Great. That actually links quite well in that response to another question we've had from Becca, thinking, how do we make sure that improvement interventions are researched and implemented on a national scale rather than just a local scale? Quite a big question.
Oh, that's a question after my own heart. So too often I see things that are actually appear to be really good interventions locally that then do not scale. Or alternatively, something that's a good idea in principle is left up entirely to local design and implementation and ends up causing new problems. And an example of this, for example, is pediatric early warning scores. They're a very sensible idea used for monitoring deterioration in children, which might otherwise go undetected. There's no national system in the UK, so there are over a dozen different scoring systems in use, and they vary so that a 5 in one hospital might mean the child is extremely sick, and in another hospital might mean that the child is extremely well. And that causes all kinds of challenges as you move around the system, and you've got doctors moving, nurses moving from one setting to another. But it also means they can't all be right, and that the clinical thresholds aren't validated. So I think it goes back to what I said to the previous speaker. I think we have not yet found the right balance between standardization and localization. And it tends to become quite emotional very quickly. And what I would like is to have this collaborative infrastructure so we can do this kind of thing much better.
Thanks, Mary. Going to our next question, and this idea of kind of the soft intelligence. So Jane Lewis actually was wondering if you could say a little bit more about the idea of systemizing soft intelligence and how we can do this without losing its rich softness.
Yeah, I love that question too. These are great. These are really great questions. So I think the first thing with soft intelligence is to recognize its value, and there's a sort of hierarchy of status, for want of a better word, for different forms of evidence. And I think it's easy to think something that is soft is something that's not valuable. But as we know in engineering, something that's soft can be the thing that's preventing crashes, the thing that is holding the whole thing together. So I think the first thing is to recognize the value. The second is, once you have done that, is to recognize that you can get that kind of soft intelligence in multiple different ways. I'm increasingly a fan of simulation, and I'm a huge fan of Victoria Brazel, who's developed all kinds of techniques for essentially squeezing the soft intelligence out of running simulations, because she runs a real clinical scenario through the system. And then she uses these extremely powerful debriefing techniques. So people learn about themselves, they learn about each other, they learn about how they're interacting with the system, they learn about how they're interacting with the patients. And the patients can be part of these simulations as well. And having that kind of structured method, I think it kind of brings to light in a very powerful way things that would otherwise remain concealed, and it makes them safe to talk about if it's done really well. So that's another example. I think the listening is really key. I was so impressed with that nurse spending the day with the environmental hygienist. That listening, the watching, the respecting what's being done. So I think there are all kinds of really, really highly effective ways we could get to that soft intelligence. I think what I would hate is for it to become monetized in some way or seen as another tick boxy. I think you have to value it for what it is.
Very interesting. I'm very happy you're answering these questions rather than myself, because they are very good ones. I might, following up on that question, insert in one of my own, which is just this issue around the role money plays that came out in the last plenary as well, and the positive and negative role that it can play in promoting different types of evidence or research, as well as you really talked about in practice and the negative role
Yeah.
it can sometimes play in terms of practice and in terms of incentives. Do you have any thoughts about how we can use money as and funding as a positive force for change around evidence-informed practice?
Yeah, I often think with money, there's a couple of things that there are many things it does, but one of them is I like to think about it in terms of its contribution to the attention economy. And there are only so many things organizations and professionals can pay attention to. And if the attention is being sucked up into things that are going to be paid for, then you've consumed the available attention for doing other things. So we have to be very careful what we put the money into, because that prioritizes how people spend their attention. The second thing is the way the money can create kind of statuses about what's valued and what isn't. And I mentioned during the talk the kind of sense that people begin to feel oppressed, that it devalues some aspects of their professional behavior and so on. And I think, again, we just have to be really careful, both in practice and research, about what we reward through financial incentives. And an example I very often use is how little money is invested in studying training. Training and consumes hundreds of thousands of hours every year. We have an extremely poor evidence base for it in healthcare. We continue to spend money on it. We spend money on the training, but then don't spend money on creating an evidence base for it. And it means training has this kind of abject status where it's somehow not regarded as an intervention, even though it's a thing we do most often as a patient safety intervention. And it's so crucial to quality of care that people are technically proficient, confident in what they're doing. So I do have a lot of thoughts on money, but there are two of my key ones.
Thank you, Mary. So go to another problem here, a question here from Cordelia. Are there any problems you have come up against where convincing evidence has made no difference in the face of lack of political will or other barriers? Or to put it differently, what do you think is needed alongside evidence to drive change in health systems context?
Okay, well, that is a very hard question. The answer to the first part is multiple examples of where you've got really high quality evidence and it makes no bloody difference to what gets done. And I think there is a kind of craft of achieving impact. There's a kind of gap between research and understanding of how politics works and how politicians work and how things get turned into policy, which kind of goes beyond the translational agenda. I think it's easy to think about research findings being on a kind of pathway or a pipeline and so on. And there is something about, again, it goes back to the economy of attention. It goes back to timing. It goes back to whose ear you have at a particular time. It goes back to what the priorities are in terms of strategy and policy for a particular year. What I have found, I think, is that sometimes you can say something at a particular time and it kind of just dies in the water. Nobody wants to hear it at that time. And then the problem may come into prominence a couple of years later or in a new form. And it's at that point that you kind of need to be poised and able to mobilize and put your evidence forward again. But there's certainly no direct relationship between quality of evidence and what actually happens in policy or in practice. I'm kind of reluctant to say researchers need to get better at this game, but researchers need to get better at this game. I think there is still a kind of tendency to put things out there as if the main audience is other researchers. And ultimately, if we want to make a difference for patients, which is what I'm absolutely committed to doing, then we have to find ways of making sure that research reaches the right audiences, makes the difference. And that starts right at the beginning, co-designing projects with staff and patients, making sure the questions you're asking are the ones they want answered and so on. And I have put, I have a large grant for my institute, and I have put a very large proportion of the funding into my communications function, specifically so we can address this challenge.
Very interesting, Mary. And I think this is a challenge that's arising again and again in these discussions with the conference.
Yeah.
And understanding things from both sides. I'm going to go pick up on the idea of co-design here, and of the varying viewpoints, with a question from Joel, who asks, how should we balance the differences of what quality means in care for different practitioners and patients? For example, quality of care in the context of dialysis might differ across patients and providers.
Okay, very, very interesting and thoughtful question. And I think it is consistent that you find that there are variations in the kind of dimensions of quality of care that are valued by different stakeholders. That's kind of a known issue. But I think we aren't always very good at systematically discovering what they are for each clinical area. With dialysis, you can see that there may well be a tension between patients' convenience. Convenience sounds a bit trivial, and I don't mean that at all, but patients wanting to be able to organize their dialysis around their work, their home life, and so on. And what might matter for practitioners may be the more clinical aspects of care. So I think there's something important about surfacing those different priorities, and then having dialogic approaches so that they can be reconciled. And again, I'm increasingly keen on consensus building methods, participatory methods, so you can expose these. I think they're kind of unspoken assumptions some of the time, and come to a shared understanding of what good looks like. We're doing an awful lot of work now on what good looks like, and it's often quite different from what I think it's going to be at the beginning. And bringing together the different stakeholders helps you to understand what the different perspectives are, what the different values, priorities, considerations are. And there's something about listening both to patients and staff and letting them hear what each other think. That means you can sometimes get to a much better vision, and that then helps drive how you design the services.
Great, thank you, Mary. I'm going to again insert in one of my own questions in thinking about co-production. What about kind of co-production with policymakers, and kind of that? So we talk about it in terms of co-production with patients and those who use services. But
yeah,
how do we kind of bridge this gap between research and practice and policymakers? And is there a role for co-production with policy there?
Yeah, I'm not sure I would use the term co-production, because I think that's got quite a specific meaning in the context of the patient-professional relationship and the valuing of the work patients have to do and in producing their own health. So, but I do think there is a very important role for co-design with policymakers. And again, that's increasingly what we've been trying to do with this institute. So choosing questions that are framed so that they're kind of optimized from the beginning as answering a policy need, but that also answer the questions that patients and staff want answered. So essentially, right from the beginning of the study, you've got something that there's an appetite for. And then including those perspectives as you're building the study. We've just been talking about what good looks like. And we published a paper about 6 months ago that I showed during the presentation, the 7 features of very safe maternity units. And we co-produced, we co-designed that entire thing with policymakers, with staff, and with service users. And it's been incredibly impactful, because we were answering the question that everyone wanted answered, and everybody got to contribute to the vision that eventually emerged. And it was very, very clearly evidence-based. So I think there are ways of doing this, but it does involve starting with policy need, understanding how you incorporate the perspectives, really listening to people, and kind of collaboratively building what the thing is you're trying to achieve and how you're going to achieve it.
Great. Mary, I'll do one more question. I think so. This is again from Joel, thinking about in the context of a stretched healthcare workforce, how do we get buy-in to do good, rigorous quality improvement work, which is at times additional work on top of everyday business of providing care to patients?
Yeah, again, this frustrates me, that sometimes the QI work is somehow seen as kind of discretionary. It actually goes back to the question you asked earlier about money. You can't, and I don't think too often the question isn't asked, what do we stop doing in order to do this? So that business of what do we need in order to deliver this, I feel hasn't been answered. The quality improvement work is not understood sufficiently as having structural components. So I don't think there is an easy way of saying, there isn't an easy answer to the solution of getting people to do quality improvement work. I think it's a systemic problem that needs to be addressed systemically. And I think there's still a problem with people being asked to do QI work that's poorly evidence-based and that actually isn't going to produce the outcomes. So we've seen many examples of that, the introduction of that nursing tabard. That actually takes, purchasing decisions, getting people to wear them. None of that is cost free in terms of time or money, and yet it doesn't really make any difference. So that's frustrating. And again, I know I've said this several times, but I think collaboratively building these things, valuing what people do, valuing their ideas, valuing their perspective right from the beginning, helps you to design improvement interventions that are A, going to work, and B, take account of the realities that people are working in.
Thank you, Mary. Absolutely very powerful presentation and responses in the question and answer here. Here in the UK, it's sunny, so I won't leave people much longer, but just to kind of briefly flag some other things for tomorrow. There are on the portal 109 different short presentations with the tag of health. Some really, really great ones, wide spanning from thinking of experiences of Pakistan and integrating mental health with primary care, mechanisms underpinning successful scale up in public health, thinking about supporting the pandemic response in New South Wales through rapid reviews, synthesis, and reporting of evidence. We have a stellar lineup for tomorrow as well. For the UK time, from 7:30 in the morning, there is a presentation on evidence-based policing. And then there is an excellent keynote by Professor Sue Dobson from the Said Business School at 10 a.m. About leadership for transformational change. And at 3 p.m., Professor Bruce Chorpada will be presenting, followed by a fab invited panel on common elements in practice. So I hope that many of you can join us for that. I'm getting the blinking lights, which I think means it's time for us to call it a day, and for you to join again when the timing allows in your country. So thank you all very much for the excellent questions, and a particular thank you to Professor Mary Dixon-Woods for this amazing presentation and slides and answers to questions and discussions there. Thanks all.
Pleasure. Thank you. Thank you.